This presentation is on cultural diversity. And in this presentation today, we are going to hit on what is cultural diversity, lots of terminology around culture and cultural diversity, as well as how we can go about delivering culturally competent nursing care. Cultural diversity is important because our country, the workplaces that we are in, our schools are increasingly consist of various culture, racial, and ethnic groups. We can learn from one another. But in order to do that, we first must have a level of understanding about each other in order to facilitate that collaboration and cooperation. And this ties into what your textbook starts out the chapter with, and that is the essential knowledge and skills for understanding cultural diversity and providing person-centered, culturally respectful care have become essential components of nursing practice. Your book defines cultural diversity as the coexistence of different ethnic, biological, sex, racial, and socioeconomic groups within one social unit. So when we think about what that entails, those groups within one social unit, these can include, but they're not limited to, varying cultures. We may see different racial and ethnic origins. We may see varying religion or language. This can also include just physical size, age, and gender. Sexual orientation could include disabilities, socioeconomic and occupational status, and geographical location. So when we are thinking about cultural diversity, we are thinking about what groups consist in a social unit. It could include some of these different types of groups. Culture is an integral component of both our health and illness because of the cultural values and beliefs we learn in our families and communities. Your book defines culture as just a shared system of beliefs, values, and behavioral expectations that provides social structure for daily living. It goes on to talk about the National Institute of Health, or the NIH, and its definition. And it defines a culture as a combination of body of knowledge, body of belief, and body of behavior. When I think about culture, I think it is what shapes us. It shapes our identity. It influences our behavior. Culture is our way of being. It refers to the shared language, beliefs, value, norms, behaviors, and material objects that are passed down from one generation to the next, which ties into exactly what these bullet points are. Culture is our personal identification. It's the language we've been taught. It's how it influences our thoughts and our communication with others, the actions we'll take, what is our customs and our beliefs and our values. Institutions specific to, and it also culture is institutions specific to ethnic, racial, religious, and geographic or social groups. What we know is nurses who practice person-centered care understand these elements, understand that these elements influence beliefs and belief systems surrounding health, healing, wellness, illness, disease, and the delivery of our health services. And so when we think about cultural respect is what enables nurses to deliver services that are respectful and responsive to the health beliefs, practices, and cultural needs of our diverse patients. This is more terminology from your chapter in your textbook. And when we think about culture, it's important to realize that we can have subcultures within a culture. And the definition for subculture is just large group of people who are members of the larger cultural group, but who have certain ethnic, occupational, or physical characteristics that are not common to the larger culture. So, a subgroup of healthcare culture is nursing. Nursing has a different occupational focus concerning patients that are not always as common to the larger cultural group of healthcare workers. Also, terminology that's in your textbook is groups in society, and it defines that we have dominant groups and minority groups. So dominant groups, usually the largest group, are considered the group that has the most authority to control values and sanctions of society. And then minority, those are the smaller groups, and they have a physical or cultural characteristic that identifies the people as different from that dominant group. And we're going to talk about in the next slide those minority groups and assimilation into cultures. So as I said, we can have dominant groups and then we can have minorities. Your textbook describes cultural assimilation as the minorities living within a dominant group lose the characteristics that made them different. Their values may be replaced by those of the dominant culture. We think, another way to think of it is cultural assimilation happens when two cultures or groups of people influence one another. Sometimes, the assimilation may be voluntary, sometimes it may be involuntary. Some examples I think of with assimilation, and they're just kind of common ones that we see every day that we may not even think of as being cultural assimilation. The development of Tex-Mex food. This is an example of cultural assimilation. It's a unique twist on traditional Mexican cuisine, and that traditional Mexican cuisine has been blended with food preferences in the southwestern region of the United States. And so now the foods cooked in the Tex-Mex style combine the elements of both cultures. And you wouldn't think about that as being maybe cultural assimilation, but that is kind of probably many of our foods in our society have come to be because of that cultural assimilation. Another example is regards to how people dress. A woman from the United States or Western Europe who moves to a country or visits a country where it's traditional for women to wear head coverings, they may adapt to that cultural norm. They may have cultural assimilation where they start to incorporate that into their wardrobe. So those are just a couple of examples of cultural assimilation. Your book goes on to define cultural shock. And so these are feelings a person experiences when placed in a different culture that is not their own. And it can result in some psychological discomfort or disturbances. When we go and visit and, on vacation, maybe we go to a foreign country. We call it the honeymoon stage. In the beginning, we're very open to the new place we're at, trying new foods, exploring the environment we're in. But if we had to be there for a long enough period and we were in a country where maybe they spoke a different language, we might come into where we started to feel frustrated because maybe we would be unable to really communicate. This might impact our ability to catch a bus or order food in a restaurant. That frustration may come. And that's, the beginning of that cultural shock. And then with cultural shock, a lot of times you'll see adaptation. We've come to terms. We start to learn some of the language and the culture that is around us. But cultural shock in the beginning can result from psychological discomfort and disturbances, especially if we're not able to really adapt to that. An example, I was trying to think of some examples where you may have cultural shock. Here in our country, when we use the restroom, we use toilet paper. There are some Asian countries such as Thailand, India, parts of Africa, and some Muslim countries such as Morocco, where using water and your hands, not toilet paper, is considered much cleaner than using toilet paper and the preferred way to clean. So if you were to go to these countries and need to use the restroom, they probably will not have toilet paper for you. That may be a cultural shock, um, and may be even frustrating to you. And so that's kind of an example of, kind of reversed of how cultural shock could impact you. Could you go to another country? Um, and then we're going to go on. We're going to define some other terms here in our next few slides as well that are in this chapter. Your textbook talks about race as far as more cultural terminology. And it considers race as a way of categorizing people into subgroups according to their physical characteristics. We typically, based on specific characteristics such as skin pigmentation, body stature, facial features, hair texture. There are 5 major categories for race that we have identified here in the textbook: American Indian or Alaska Native, Asian, Black or African American, Native Hawaiian or other specific islander, and white. Further, when we talk about cultural terminology, we also need to describe what ethnicity means. And that's that sense of identification with a collective cultural group. It's largely based on the group's common heritage. One can belong to an ethnic group through birth or adoption of characteristics of that group. A very good example that we always like to use for this is Mrs. Farmer. She adopted a child from China. And so while that child may be ethnicity, she appears to be Asian, she considers herself American because she has been raised, she's been adopted, and she has adopted the characteristics of the group where she has been grown up. Groups share unique cultural and social beliefs and behaviors and patterns, and largely develop through day-to-day life with family and friends within the community. So if we're going to deliver as nurses culturally competent care, we need to be aware of factors that will inhibit sensitivity to diversity. And so again, we go through some different terminology here. The first one being stereotyping. And that is where the assumption that all members of a cultural or ethnic group act alike. Sometimes stereotyping can be positive or negative. Some examples to give you as far as a nurse. Let's say the nurse assumes that all elderly patients are unable to really are capable of answering health questions. And so an example would be a nurse directing their interview questions to an elderly patient's daughter, even though the patient is perfectly capable of answering them. That would be the nurse stereotyping. She has already made an assumption about elderly patients, and therefore she is not treating that patient with patient-centered care. She is stereotyping and automatically referring her interview questions to the patient's daughter. Another stereotyping example might be a nurse refuses to care for a married gay man who is HIV positive because she is against same-sex marriage. So again, that could be stereotyping, making already an assumption about a member of a culture or ethnic group. And those would be both very negative type stereotyping examples. When we think about cultural imposition, that is the belief that everyone should conform to the majority belief system in healthcare. This is a tendency for the healthcare personnel to impose their beliefs, practices, and values on the people of other cultures. When I think about cultural imposition, An example might be a hospital nurse tells a nurse's aide that the patient should not be given a choice whether or not to shower or bathe daily. That would be a cultural imposition example by the nurse, not allowing patients to have a choice. They must conform to her belief system. Another one might be, let's say there's a Catholic nurse, and maybe there's a patient who's been diagnosed with terminal cancer. Maybe they're in the end stages of their disease process, and she insists that the patient see a chaplain. Well, that's really her thinking that everyone should conform to her major belief system. And so we need to try to make sure we are not providing those type of examples. We're not performing cultural imposition with our patients. Ethnocentrism is the belief that the ideas, beliefs, and practices of one's own culture are superior to those of another culture. And it really closely relates to cultural imposition. Some things to think about with ethnocentrism is, Americans tend to value technology advancement and accumulation of wealth. And American applying his or her own standards to a culture that does not value those things, they may view that culture as primitive or uncivilized. Such labels are not really just statements, but judgments that imply that it is better to be an American, to have urbanized and industrialized lifestyle. And so that would maybe be an example of ethnocentrism. Another one to think about is people in other cultures, such as maybe European cultures, they see American culture through the lens of their own ethnocentrism. So to members of other cultures, Americans can seem very materialistic, brash, arrogant, maybe lack, spirituality. And I think many Americans would disagree with that assessment. So those are some things to think about with ethnocentrism. Again, it goes very closely hand in hand with cultural imposition. When we think about cultural blindness, this is where we ignore differences and proceed as if they do not exist. We pretty much treat everyone the same, and we're really only meeting the needs of a dominant group when we treat everyone the same. Much of, I think, cultural blindness, history-wise, probably came about with the civil rights movement. And that was where services that were offered in response to the civil rights movement were thus developed to treat everyone equally and not necessarily to treat everyone with his or her best interest in mind. So we want to be careful that we are not just treating everybody the same. And again, it comes back to that patient-centered care. We need to deliver services and support our patients and not ignore their cultural strengths or their attitudes towards something that they value. And sometimes it can be it can be almost, when we do cultural blindness, we're almost like blaming the consumer when they have not conformed to what we think treating everybody the same is. I was trying to think of examples, and I don't know if you've ever heard this in your lifetime, but I think about if you've ever overheard a person or a healthcare worker who maybe is interacting or caring for a non-English speaking patient, and they make the comment, you people should learn to speak English. That's cultural blindness. So that's kind of an example of that. When we think about cultural conflict, um, again, that's where people become aware of the differences and they feel threatened. The response is ridiculing beliefs and traditions of others to make themselves feel more secure. So an example of that might be a nurse tells another nurse that Jewish diet restrictions are just a way for them to get a special tray of their favorite food. Well, that would be ridiculing that patient's belief or traditions and possibly making that nurse feel more secure. So that would be an example of cultural conflict. So cultural influences on healthcare. Again, we've kind of talked about wanting to give culturally competent care. Your textbook defines cultural competence as knowing and utilizing the culture of another in assisting with the resolution of a problem. And when we want to deliver that cultural competent care, we have to also consider the following elements in providing that. The first is physiologic variations. What is this patient's reaction to pain? Mental health, gender roles, their language and communication, their orientation to space and time, food and nutrition, their family support, and their socioeconomic factors. And we are going to go through the next few slides and talk about a few of these as far as what we should consider in each of these elements. Physiologic variations that we should consider in order to give competent care is to realize that different populations have more of a risk for common health problems. For example, African Americans, there has been research to show they are at higher risk for hypertension, stroke, sickle cell anemia. Whites tend to be at higher risk for breast cancer, heart disease, hypertension, diabetes. Hispanics, diabetes, etc. This is a book to show you some of these. This is a table that was taken from your book to show you some of these examples of physiologic variations that we are aware of through research, that we have seen that there are more common health problems, certain types, with certain populations. So that is something as a nurse just to be aware of when we're caring for our patients. Culturally competent nursing care in relation to patients in pain. We talk a little bit in the pain chapter about pain is whatever the patient says it is, whenever the patient says it's happening or where it's happening at. We know that sometimes patients don't react to pain in the same way. We need to recognize that each person holds various beliefs about pain and that pain is what the patient says it is. We need to respect the patient's right to respond to pain in one's own fashion. We never want to stereotype a patient's response to pain based on the patient's culture. We need to be very sensitive to nonverbal signals of discomfort, such as holding or applying pressure to the painful area or avoiding activities that intensify the pain. Again, in some cultures, it is a sign of strength to be able to endure pain. So again, we want to clue into those nonverbal signals, even though our patient may be saying that they're not having pain. That may be in a cultural influence regarding their pain. And nurses should not assume that the patient who does not complain of pain is not having pain. To deliver that culturally competent nursing care, we need to be aware of communication style. As far as verbal, we need to have an awareness of our vocabulary and our loudness. We want to understand what language does the patient speak, and how well do they speak and write English, because that's going to determine whether we need to provide some type of interpreter so that they understand what we are saying. How does the patient wish to be addressed? That's very important as far as communication. We need to walk in and we need to, refer to them as Mr., Miss, Mrs. And then, let them tell us, whether they want to be called by something else or not. It's very important, even if the patient speaks English, but we know that maybe English is a second language, do they know how to read it? Because a lot of times in healthcare, we're giving discharge instructions in writing for the patient to go home. And so it would be good to know in communication which style would they prefer. Would they prefer their directions in their native language or in English? We also need to be aware of our nonverbal communication and have an understanding that nonverbal communication may have a different meaning for the client than it does for us. When we think about that, we think about our touch, eye contact, facial expressions, and body postures all vary among cultures. In some cultures, it is not appropriate to make eye contact. And in other cultures, it's not appropriate. They don't respond well to touch. So anytime we're going to do anything with our patient, we really need to explain what we're going to do before we touch a patient. We, need to observe the patient's facial behavior. Are they accepting of our nonverbal communication? We need to be careful that we don't interpret a client smiling and nodding to us to mean that they understand what we're saying as well. Patient nutrition is another area to be aware of when we're thinking about culturally competent nursing care. I was looking for, examples to give about cultural shock that we talked about in the previous slide. And I was reading about how some cultures serve rats or, different foods that we would never dream of eating here that might cause us to go into cultural shock. Well, the same could be true for patients here in the United States that we're taking care of that are from another country. So when we think about nutritional patterns, sometimes it's very important the way food is served and prepared, that is related to the culture. And some foods are traditionally only for certain holidays. When I was a school nurse and I worked in the school, I believe it was the Orthodox Jew, possibly students, that their parents would always call. They were very concerned about the lunch menu because I believe they were not allowed to eat pork. So that is something to be considerate of with nutrition. Different cultures believe in breastfeeding versus bottle feeding for infants. Different cultures will have different recommendations for when to introduce solid foods to an infant. And as I just mentioned that example, some foods are required and some are forbidden. When we are assessing for the possible cause of a patient's decreased appetite, it is very important to try to determine whether the problem may be related to their culture. Maybe we are not providing the foods that they are accustomed to eating that sound good to them. We want to have dietary teaching that's individualized according to the cultural values about the social significance and sharing of food as well. When we are thinking about providing that competent nursing care related to nutrition. Another consideration is the orientation to space and time, so our personal space. And this is defined as the area around a person regarded as part of the person. We consider that area to us that no one should intrude during personal activities. That personal space can vary among different individuals. Some people may be very comfortable being up close talking in somebody's face, while others may want to keep backing up from you because they're not comfortable. You're in their personal space. When we are providing nursing care that involves that physical contact, The nurse needs to be aware of that patient's cultural personal space preference. It's why we always say we should explain a procedure, we should explain what we're doing, and kind of let the patient say, okay, and go ahead and perform your head to toe assessment, because we are trying to be culturally competent and we are trying to be aware that we are invading maybe that patient's personal space. Time orientation also. We have people in our own society that are always on time, very punctual, and we have the people that always run late. If they need to be there by 3, you need to tell them 2:30 so that they're actually there by 3. But time orientation refers to a person's focus on the past, present, or the future. Some cultures value promptness and punctuality as a sign of respect, while other cultures consider being late a sign of respect. And that plays into hand when we are thinking about, our patients going home, but they need to have a follow-up appointment visit. Well, if they're from a culture that, the appointment's at 1, that means you can come anytime between 1 and 2. It's important they understand that they need to be on time for their appointment. They need to take medications at a certain time and be, in order for them to be the most effective. So that time orientation does impact our nursing care that we are giving to our patients. Elements of cultural competence, we're going to continue with that here. And your book talks about providing culturally respectful nursing care means that care is planned and implemented in a way that is sensitive to the needs of the individual. That is what patient-centered care is all about. And when we're providing that, we have to be culturally respectful. In order for us to really do that, we need to start developing a self-awareness. We need to begin to demonstrate knowledge and understanding of a patient's culture. And many times, we may not have an understanding of that culture until we start taking care of that patient. And that's where we may need to pull resources and learn that knowledge as we're taking care of that patient so that we can understand that patient's culture. We need to be accepting and respecting of cultural differences. Just because I am Catholic and maybe the patient I'm taking care of is Jewish, doesn't mean that we can't learn from each other, but we need to be very accepting and respecting of those cultural differences. We need to not assume that the healthcare provider's beliefs and values are the same as the client's. We have a very sick patient and they need a blood transfusion. We should not believe that that patient's beliefs are the same as ours and to go ahead and consent to the blood transfusion. Maybe that patient is a Jehovah's Witness and they don't believe in blood transfusions. So their beliefs may not be the same as what I am considering the best path or the best way to treat that patient. So we should not assume that. We need to resist judging or having judgmental attitudes. Just because something is different does not mean that it's not good. Being open to and comfortable with cultural encounters. And we're going to be accepting responsibility for our own cultural competence. Your book talks about the National Center for Cultural Competence. And it urges healthcare professionals who value cultural competence to enhance their understanding of the following. So these are assessment areas that nurses need to have an understanding of. And that includes beliefs, values, traditions, and practices of different cultures. Culturally defined health-related needs of individuals, families, and communities. Culturally based belief systems of the cause of illness and disease and those related to health and healing, attitudes towards seeking help from healthcare providers. When we are caring for patients from a different culture, it's important to first ask how they want to be treated based on their values and beliefs. An effective way to identify specific factors that influence a patient's behavior is to perform a cultural assessment. I think as we move into being more culturally diverse, there's awareness in our society, We will see more of these type of assessment questions based on culture implemented into that admission process, or those questions we ask on admission. Your textbook gives some examples of a transcultural assessment as far as questions that would be on that. It is in your textbook on page 91. It is box 5-5 if you want to look and see what that involves and the questions you would ask a patient in that type of assessment. On this slide, I wanted to make sure in this chapter that I included all the terminology from this book. And another term that was discussed is transcultural nursing. And that is a field of nursing that studies different cultures, values, beliefs in order to provide cultural specific nursing care. And we can all practice this. It is caring for a client while taking into consideration their religious and socio-cultural backgrounds. So we can all practice transcultural nursing. We just need to do an assessment, understand what that patient's cultural, their beliefs, their values are, their attitudes, and be culturally sensitive to that and provide that individualized care. As we conclude this presentation, we're going to talk about on this slide some guidelines for providing culturally competent nursing care. And then the next slide, we're going to talk about just some general tips that we can do. And again, we've kind of repeated these a couple of times in the previous slides, but we have to develop a cultural self-awareness. We need to develop cultural knowledge about the patients we are taking care of. We need to work toward accommodating cultural practices in healthcare, making it culturally sensitive to that patient, individualized care that is taking into consideration that patient's cultural preferences. We need to have respect for culturally based family roles. It is common in some cultures that, all questions, you have a female patient, but all questions she wants directed to her husband. That is, having a respect and providing that, doing that, if that's what the patient requests, because that is respect for that culturally based family role. We need to avoid mandating changes. Again, we don't want to be culturally insensitive, have that cultural imposition because we're mandating that patient to do something that they don't want to. They don't want to change their beliefs. And we need to seek cultural assistance when we're unsure how to handle a situation. Some cultural care tips to take with you as you head into, beginning to take care of patients in the clinical setting is to be aware of our own cultural heritage. An example would be, as a nurse, how do you value behavior with pain? Being aware of your own. Become aware of the client's culture as described by the client. We don't want to stereotype patients. We want to identify the client's preference in health practices, their diets, their hygiene, and that goes back into some of those considerations we've talked about in the previous slides. We want to incorporate clients' cultural values, their practices, and beliefs into their nursing care plan, how we plan their care. All those should be considerations. If the patient wants to have a prayer service every morning at 9 a.m. because that is their belief and their practice, then we need to take that into consideration. We need to make sure that any interventions or, anything we're trying to implement with the patient, that maybe we avoid that time frame and work around that. And we need to put that in their plan of care. We always want to address the client by their last name unless they give us permission to do otherwise. That goes back to that communication and just showing a respect for our patients. When we go into a room, we're always going to introduce ourselves by our name. We're going to be honest about the knowledge that we lack about their culture. Is it okay to say, I don't know much about your culture. Can you tell me more about it? And that's okay. We want to be honest with our patients. We're going to use language that is culturally sensitive. So we may want to use terms, the patient may want the term used of gay or lesbian and not be called a homosexual. African American or Latino may be more respectful for the patient than calling them Black or Hispanic. And again, those are questions that you're going to have to ask your patient. What ethnicity do they refer themselves as? In the classroom, when we would be in the classroom for this presentation, I've had different students say different things. I've had students tell me they prefer to be called African American, and then I've had other students who say, I actually prefer to be called Black. So again, that is a preference that we need to be culturally sensitive to. We need to ask those questions. Another example given here is referring to Asian, not Oriental. So we need, the next bullet point, if we're not sure, we need to ask the client what term is preferred. We, as nurses, need to keep up with language changes and show respect for clients' support people as well, those that are with them. So those are some cultural care tips. Again, this presentation is to help you just have a cultural awareness as you're going in to start taking care of patients. How can we give more individualized, patient-centered care that is culturally sensitive to our patient?